Vasodilation, this causes uh, decrease in renal blood flow. So decrease in renal blood flow. Due to this, there is a activation of RAS. This causes vasoconstriction, decreased urine output, due by increased cardiac output. This hepatorenal syndrome. The complications include hepatic encephalopathy due to ammonia deposition and fetal hepaticus, ascites, hepatopulmonary syndrome, hepatorenal syndrome, splenomegaly, cirrhotic cardiomyopathy. So, investigations which is evaluation of portal hypertension. So, investigation in portal hypertension includes assessment of liver function, complete blood picture. Assessment of liver function include liver bilirubin levels, aspartate alanine transferase, aspartate transferases, aspartate aminotransferase, alanine aminotransferase, and alkyne phosphatases, serum bilirubin, serum albumin, coagulation profile, prothrombin and hepatitis B, C markers, complete blood count, anemia due to GFB. Investigations, imaging investigation done in portal hypertension includes ultrasound abdomen with Doppler. Most important is it in ultrasound abdomen with Doppler, there is increased of a dilated portal vein of more than 13 mm. There is splenomegaly, there is ascites, there is collateral circulation formation. In CT scan, it detects a portal vein any thrombosis or collaterals. In MRI or MR photography, detailed evaluation of portal vein system. Endoscopy use upper GI endoscopy to see an esophageal bleeding or varices, gastric varices. Okay. In special investigation, hepatic venous pressure gradient. It is important. HPVC. Hepatic venous pressure gradient 5 to 10 is normal. More than 1 to 5 is normal. 5 mmHg is portal hypertension. More than 10 is clinically significant. Splenoportography, contrast study of portal vein system. Liver biopsy determines cause of portal hypertension, as in cirrhosis and fibrosis. In acidic fluid test, we have to do, and transient elastography also we have to do. Management generally it has splenomegaly, so there is blood restriction. So anemia we have to treat. Vitamin K, because of liver function failure, we have to give vitamin K. Nutritional supplementation, blood and blood transfusion if required. Specific measures for to decrease portal hypertension, drugs like beta blockers, propranolol and nadolol, and surgeries include a portosystemic shunt, transhepatic transjugular intrahepatic portosystemic shunt, and liver transplantation, and treat esophageal varices, treat splenomegaly, hepatic encephalopathy, prevention by giving the lactulose syrup, treatment of ascites. So what is portal hypertension? Portal hypertension is defined as a more than 10 mmHg of portal venous pressure. The causes include prehepatic, hepatic, and posthepatic. Prehepatic causes include the portal venous thrombosis, any perihepatic, periportal inflammation, trauma, neonatal umbilical sepsis, and extrinsic compression from the pancreas or gastric stomach. And in hypocoagulable states. In intrahepatic, it includes intrahepatic conditions includes cirrhosis, hepatitis, and portal vein thrombosis, nodular hyperplasia, congenital hepatic fibrosis, Wilson's disease, hemosiderosis, increase in iron deposition, Wilson's disease, increase copper and cellular plasmin levels, schistosomiasis, primary biliary cirrhosis. In posthepatic, right heart failure, Budd-Chiari syndrome, congestive heart failure, and cardiac failure, veno-occlusive diseases. Budd-Chiari syndrome, congestive heart veno-occlusive diseases, and constrictive pericarditis. Clinically single triad of splenomegaly, esophageal varices and ascites, and also jaundice, increased infection charges, coagulopathy, hepatorenal syndrome, hepatic encephalopathy, and that flapping tremors, and upper GI bleeding, the features of liver cell failure, and Kenavi's sign. Kenavi's sign is important. Venous hum heard or inspection over the epigastrium during inspiration due to portal hypertension. The complications include hepatic encephalopathy and ascites, and then hepatorenal syndrome, hydropulmonary syndrome, splenomegaly, hepatic cirrhotic cardiomyopathy, varices. Management generally we have to control anemia control, and vitamin K injection we have to give as a liver cell failure occurs, and Good nutrition supplementation, blood and blood transfusion if required. Specific treatment includes treatment of esophageal varices, hepatic నేను చదువుతున్నా పెట్టి ఊపినాడట అరే నీకు ఇదే కదా చెప్తున్నా టీ కాదు ఇట్లా అన్నా కాదు కానీ నేను చదువుతున్న పైన తీసి కింద దీనిలో పెట్టినాడు నార్మల్ చెప్పొచ్చు వాళ్ళు ఏం కడతారు వాళ్ళు పెద్ద కాలు దండ పెట్టి లాకర్ రూమ్ అంటాడు కాలు పెట్టి లేపుతాడు పోయి కాలు పెట్టి కూడా నువ్వు Symptomatic treatment include we have to advise the patient to take bed rest, adequate nutrition, high carbohydrate diet, avoid any alcohol and hepatotoxic drugs, and symptomatic treatment for nausea, vomiting, malaise, headache, generalized body weakness, general symptoms, pain, and headache. Prevention includes general safety measures, safe drinking water, safe food practices, hand hygiene, proper sanitation. Vaccination include hepatitis A vaccine and proper passive immunization include human immunoglobulin. Vaccination hepatitis A vaccine, passive immunoglobulin. It is usually self-limiting. Complete recovery occurs within 2 months and no chronic carrier state. So hepatitis A, RNA virus, non-encapsulated Picovirinidae family, highly infectious. Fecal route of transmission, incubation period of about average 4 weeks, no chronic infection, no carrier state, mild self-limiting, vaccine is available, passive immunoglobulin and IgM antibody is detected in serum. Pathogens include infection gets into GI tract through bloodstream. It affects liver and causes hepatocellular damage and hepatocellular inflammation. Whereas excreted in blood and bile.